Today, I want to share with you a little bit of the potential of my two favorite MIGS devices, Cypass and KDB, on a case of traumatic aniridia status post extensive reconstruction, pars plana vitrectomy, iris prosthesis, sutured PCIOL, corneal transplant. Despite all this beautiful surgery done elsewhere, the eye was headed towards blindness due to secondary glaucoma. As you can see, this is a one-chamber eye as a whole tube of viscoat disappears into nowhere. The view with the Hill gonial lens is difficult because the corneal transplant is cloudy right at the edge of the host donor, right where we're looking. But as you can see just to the right of center, there's a clearer area and less anterior synechia. In cases like this, with traumatic aniridia, the anterior tips of the ciliary processes tend to form synechia anteriorly, and so I'm using the anterior tip of the Cypass to attempt first to bluntly dissect posteriorly to obtain access to the supraciliary space. With this first attempt, I'm not able to obtain access to the supraciliary space, but I am able to dissect the synechia posteriorly so that we can then see what would be, in a normal eye, the ciliary body band. So at this point, I'm going to put some more viscoelastic in, clarify the view, and there you can see the trabecular meshwork, and you can see what would be the ciliary body band, which is where I'm going to insert the Cypass. So you can see the moment that the Cypass passes into the supraciliary space just above the ciliary processes, and you'll see it go through right there. And at that point, it's basically a routine Cypass insertion. And the device is placed initially at exactly the place where you'd like it to end up in a patient with an iris. Since the patient's aniridic, I can move it a little more posteriorly to give me a little greater access for the next part of the procedure, which is the Cahook dual blade goniotomy, in an attempt to improve the anterior drainage as well. Because we have created a completely new drain, and because we've removed the trabecular meshwork for a large area, I have no hesitancy in using my standard cataract postoperative regimen, which is cefuroxime 1 milligram intracameral and Canal 0.8 milligrams subconjunctivally. With the irrigation of the viscoelastic, you can see the Cypass in place at what would be the patient's 4 o'clock position. And current on-label approval of the Cypass is very limited, but the power of this device is easy to underestimate. As the father of the anterior approach cyclodialysis, I want to tell you this is real glaucoma surgery. From over 20 years of experience with the anterior cyclodialysis procedure, I believe it will be clear that the pre-op IOP is an independent variable from the post-operative IOP, and that patients with pressures preoperatively of 50 attain the same results as patients with pre-op IOPs of 17. Thank you.